I'll be talking about hematological malignancy are the most common cause of emergency spine surgery in patient of unknown cancer diagnosis at the time of presentation. I have no disclosures. It's a well-known fact that multiple myeloma is a medical condition. Like in this case, a 60-year-old male with 2 days of paraparesis presented with this MRI picture. The sole treatment given was radiotherapy, and within 10 days, we seen the tumor has completely melted away like a butter within 10 days. Another case of 47-year-old male with 2 days of paraparesis, known case of non-Hodgkin lymphoma, solely on radiotherapy, we have seen complete neurological recovery and tumor has completely gone. So it's a well-known, the known frameworks have given the guideline for ultra-radiosensitive tumors like multiple myeloma and lymphoma. The sole primary modality of treatment is radiotherapy. So we have a lot of literature about the stable spine with known case of multiple myeloma, but what about unstable spines? So we found this one study regarding in which a known case of multiple myeloma with unstable spine solely treated with radiotherapy alone and achieved good neurological outcomes. Another case of 37-year-old male with Asia D with known case of multiple myeloma and unstable spine and cervical thoracic region with sin score 18 with post-op radiotherapy, achieved good neurological outcomes. In our institute also, we able to get good outcome solely on radiotherapy in unstable spine also. International guideline currently recommend radiotherapy as a primary modality of treatment in hemolymphoid malignancy, unless there is some frank instability or progressive neurodeficits. So this makes us question how many emergency presentation of metastatic spinal cord compression could have been treated with radiotherapy if diagnosis could have been established earlier. Why this is an important question to us? Because radiosensitive tumor carry a high risk of DVT, pulmonary embolism, infection, and osteoporosis, especially in multiple myelomas. So we undertook this retrospective study to quantify the incidence of hematological malignancy presenting as acute metastatic spinal cord compression without prior diagnosis. And secondly, to quantify how many cases could have been treated with radiotherapy if the diagnosis could have been made earlier. We did a retrospective 12-year chart review of single institute from 2009 to 2021. Inclusion criteria were metastatic spinal cord compression with neurodeficit and no known prior cancer diagnosis or cancer-free period for 10 years. These are the exclusion criteria. And we studied these parameters, basically. I would like to share the result. We found that the mean age of presentation of patient was 63 years. 80% of the cases were male, and the most common location of spinal metastasis came out to be thoracic spine in 80% of the cases. The mean duration of deficit was 10 days at the time of presentation, and stable, we found the stable neurology, that is non-progressive neurodeficit, in 42% of the patients. Grading wise, we got in 80% of the cases Frankel A and Frankel C, and 63% of the cases had grade 3 Belinsky grade compression. Regarding the sin score, in 42% of the patient we found unstable spine, and 47% had, approximately 50% of the patient has indeterminate or stable spine. All the patient underwent surgical decompression, and 69% of the patient underwent posterior decompression and fixation with estimated blood loss of 500 ml and mean surgical time of 3 hours. After the histopathological diagnosis, we found that in 55% of the cases came out to be hemolymphoid in origin, out of which 35% of the cases were multiple myeloma. Surgical complications are like 10% of the cases we have wound dehiscence and 10% of the cases we found implant failure. Survival prognosis, we've seen that within 3 months, 10% of the patient died. In 6 months, 15% of the patient died. In 1 year, 26% of the patient died. And about approximately 80% of the patients were alive and able to follow up for 1 year. Now, ambulatory status, 31% of the patient unable to gain functional neurological ambulatory status post-surgery. The result is in total patient, 55% of the patient has hematolymphoid malignancy, and 80% of the patient had stable or indeterminate stable spine. That means at all the emergency patient, after which 42% were patient has either hematolymphoid originated malignancy or stable or indeterminate stable spine. So the question which rises is, can the surgery be avoided if diagnosis could have been developed earlier? We searched the literature and we found only one study regarding this, in which they also found the similar result, in which total 43 patients was reviewed over the period of 18 years, and 51% of the patient came out to be multiple myeloma. So I'll conclude with this, that multiple myeloma is the most common pathology in the cancer-naive patient presenting in ER with neurodeficit. Hematolymphoid malignancy are 35% of the total chunk. 42% of the patient could have been treated with radiotherapy if diagnosis could have been made earlier. The only obstacle in this case is early diagnosis, early histopathological diagnosis in emergency settings, which can be addressed with specialized emergency clinical pathway for metastatic spinal cord compression to target this problem. Thank you. I'll conclude with another 35-year-old female with paraplegia with this MRI picture underwent this extensive surgery early and eventually turned out to be non-Hodgkin lymphoma. Thank you.